Yay Networks.
Welcome to another episode of Plastic Surgery Uncensored. I'm your host, Dr. Rady Rahban. On this week's episode, we're going to be doing Q&A, question and answers. And I'm always accompanied by Maria, my producer, on these episodes where we curated your questions through Instagram and other social media. And we're going to dive in and answer your questions. And hopefully you'll hear your name or your handle shout out. And let's dive in. Hey, Maria.
Hi, Rady.
So fire away, Maria. I know that you curated these Q&As. We're going to try our best to answer as many as we can. We try to cluster some of them together because obviously there's some common themes. And then we're going to try and give you a little credit with your handle. So what you got?
Okay, well, by the way, the question on breasts is a hot topic because everybody wants to know about breasts.
Breasts are always a hot topic. That's for damn sure.
Yeah. So we have Sabasari, who asked the question, augmentation through fat transfer, yes or no? But we also have Simona Butcher, is it possible to get old implants out and get breast lift with fat transfer to the breast? So there's a lot of questions on fat transfer.
All right. So big topic. Probably out of all the questions we got, without a doubt, the common theme is fat transfer. So as everyone knows who follows and listens to the show, I like big picture discussions. So I always back up a notch. So the real question at hand is, why are we even talking about fat transfer? And the reason we're talking about fat transfer is because we're trying to find an alternative to implants. That's the basic gist of it. So there are two tools when it comes to breast aesthetics. One of them is fullness or size, and one of them is shape. To change the shape of a breast, for the most part, you need to do some type of mastopexy or lift or rearrangement. But to make the breast larger, fuller, more perky, for the most part, you need more volume. And historically, the main way to add volume that you don't have yourself is through breast implants. Now, breast implants in general have not suddenly changed or become bad for you or terrible. It's just the public perception of implants continuously changes. So implants were great for many years. Then there was the implant scare of 92. The implants were removed off the market. Then they came back in 2006, and they've been so since then. Scientifically, implants have little, not zero, issues. And while there are complications associated with the surgery, the implant themselves are pretty, as implants go, I mean, prosthetic knees, heart valves, pacemakers, they're pretty safe. The reason why we're having such a huge talk about fat transfer is there's a whole new surgence of people with BII, breast implant illness, which is basically fancy for, I don't feel good, and I think it's my implants that are making me sick. We're not going to digress because that's a whole subject. And if you know, and you go to my catalog of episodes, there's a whole episode, actually a very good episode about BII, but we're going to talk about what people are looking for as an alternative to having implants. So the alternative, or the holy grail, is my own tissue. I mean, no question. If I had a choice, my wife was here and she needed enhancement or augmentation, I could choose between a silicone implant, which by the way is an excellent option, or her own fat or breast tissue for that matter. Of course I choose breast tissue or fat. I mean, that's a no-brainer, no question. So what's the problem? The problem is it's not that simple. So here is my general idea. Whether you're having a lift with an implant, a straightforward augmentation with an implant, or removal of your old implants and replacement with an implant, the idea of eliminating the implant and replacing that with fat, in my opinion, is flawed. So listen carefully, and this is why. When you put fat in the face, it doesn't take much fat to get a major effect. Under the eyes, in the cheeks, in the lips, it takes at most 20, 30 cc's to fill an entire face. That's nothing. So the average person who wants to get facial volume restoration has plenty of fat on their body to be able to facilitate the transfer of it to their face. But when you want to get fat in your butt or fat in your breast, my opinion, again, pay attention, this is my opinion, I think that there are very few good candidates, because in order to do this, it's the idea of stealing from Paul to pay Peter. What does that mean? It means I have to borrow the fat from somewhere to put it into your breasts. Okay, that's a win-win. That's no problem. I got a lot of it. You think you have a lot of it. You think you have a lot of it. So here are the reasons why I don't like fat transfer in general, in large volume, whether that's the butt or the breast, it doesn't matter. In order to replace an implant, the average implant is about 275 cc's. That's not big at all. Now you have two of them. That's 500 cc's. Okay, 500 cc's. And by the way, that's not a big augmentation. If you're an A cup, that makes you a small C, a full B. It's not that big. In order to get 500 cc's equivalent of volume, you need at the minimum 1,000 cc's of fat. Because on average, when you put in fat into the body, you transfer it, you take it out of the body and then put it back in, 25 to 75% of it is absorbed. So if you know math, that's 50% of it is gone. It dies. Your body absorbs it. It didn't work. Because remember, this is a transfer. We take it out from your body. It's dead now. And then we put it back in your body. And then we hope, we pray that your body makes it alive again and it makes it connected.
Right.
And half of it dies. It dies. It just doesn't work. So in order to get a modest augmentation, everyone says, I just want a small one. That's bullshit. You want a modest augmentation. You may not want a big one, but you want a modest one. You want to be worth it. You need twice as much fat as what you anticipate so that you have something at the end. That's 1,000 cc's of fat. Okay, no problem. You tracking me? Mm-hmm. In order to get 1,000 cc's of solid fat, you need to take out between 2 and 3 liters of lipo, because what you pull out, half of it, if not more of it, is fluid and ruptured fat cells and all kinds of extra stuff. So if I take out a liter of fat, when it's all done and I've prepped it and made it into pure fat, a lot of it is just wasted stuff. So you can see that you're now getting more and more liposuction. So what I say to you is that to get a modest augmentation, you need about 2 to 3 liters of liposuction. That is a tremendous amount of liposuction in my eyes. Mm-hmm. So in order for someone to make a satisfactory augmentation of your breast, based on my calculations, you need a good 2 to 3 liters of lipo. And so where do we get it from? We get it from your abdomen. We get it from your flanks. That's your love handles. We get it from your upper back. We get it from your inner thighs, and we get it from your arms. Again, everyone's listening going, and what's the problem so far? I don't understand. This is a win-win. In order to get 2 to 3 liters of lipo out of the average person, I'm not talking about some very voluptuous, heavy-set woman. The average woman, you are going to create significant damage in the areas that you borrowed the fat from. Let's go over this again. When you liposuction an abdomen, yes, the abdomen gets smaller, but you always, not sometimes, not maybe, not if your surgeon's excellent, not if they use laser, not if they use Vaser, you always get irregularities. What are irregularities? Dents, divots, rippling. You get some kind of irregularity. So you take a smooth, albeit full surface, and you get a smaller, irregular dented surface. The second thing you always get is some degree of loose skin. Always. And you don't get that loose skin in 2 months or 3 months. You get it in 18 months and 24 months. So the reason why I am not a fan of large volume fat transfer, breast and butt in general, I didn't say ever, is that in order to get a satisfactory, now by the way, the butt is like this times 2. It's like twice. You need about 4 liters. In order to get a satisfactory result, you need to take a boatload of fat out, and I am more concerned about the donor site morbidity, the shit that happens to where you borrowed it from. So now you have this gorgeous set of breasts. Oh my God, I'm so happy I avoided an implant. And your arms are irregular, your back is loose, you got this weird divot in your hips, your abdomen has got some kind of dents, you're now wearing a one piece when you wore a bikini before, and your inner thighs, you got like this crepey skin. Sounds like a great trade-off. So this ideology that it's this miraculous new wave alternative to this poisonous implant is nonsense. That's the end of that. Next question.
Now, I have from Mrs. Lovely 90, when getting a breast lift, can you choose to keep all the fat and just get them lifted?
What was her name?
Mrs. Lovely 90.
Mrs. Lovely 90, shout out. So your question is, can you do a breast lift without an implant? And the answer is absolutely. There are 3 types of women that come in for breast lift. One that comes in and says, hey, Dr. Rahban, I need a breast lift and I want an add-in implant. And the answer is you cannot. Well, what do you mean? You have too much breast tissue. You can't have an implant, but I want one. You can't. There's the second type of patient that comes in and needs a breast lift and says, Dr. Rahban, I don't want an implant. And the answer is you can't. What do you mean you can't? You don't have enough breast tissue to create a pretty breast. You're too deflated. And then there's the third type. And the third type is a woman who has enough breast tissue who can choose whether or not to have a lift with or without an implant. And that, in those indications, a woman can choose to say, you know what, Dr. Rahban, I don't mind if I don't have as much upper pole fullness. I don't mind if my breasts are a little smaller. I prefer not having an implant, and that's perfectly fine. If you have enough breast tissue that you don't need an implant, then you can choose not to have one. But if you come in completely deflated, right? You've breastfed 4 kids, you've lost 100 pounds, whatever, you can't not have an implant, at least
because the result is not going to be
outcome
right
without an implant, and I won't operate on you. So,
yeah. Jamil Francesca is asking, typically, how many hours does a breast augmentation take?
Jamil Francesca. So, I think a really good indicator of those of you who listen to my episode on consultations is asking how long the procedure takes. And if you know how long the procedure should take, then when your surgeon tells you something that's really, really short or really, really long, it should be alarming, right? If I told you I'll be right back, I'm going to make you a souffle, and I'm back in 6 minutes, you haven't tasted the souffle. What is the likelihood that that souffle will taste good? 0. No souffle can be made in 30 minutes, in 6 minutes. It was cooked in a microwave or something. If I come back 5 hours later with your souffle, what's the likelihood it'll taste good? 0. A souffle has a certain amount of time it should take. Now, so breast augmentation, like breast lift, like tummy tuck, like eyelid, like noses, has a standard that's pretty good. And in my opinion, about an hour and 20 minutes to 2 hours is the standard, depending on who's doing it and how they do it. The overwhelming majority of surgeons do breast augmentations in a flash. In, out, boom, bam, 30 minutes, closed, done, next. It's a low-lying fruit. It's a volume-based surgery. When you go in and your doctor charges you $5 for your breast aug, do not be surprised that he has 9 of those lined up that day. So I think when your surgeon says you're going to be in and out in 45 minutes, by the way, in and out means prep and clean you up and get out, means the surgery itself took 30 minutes. I think that's alarming. It should be about an hour and 15 to 2 hours long.
Is it the same procedure to put the new implants as it would be to replace existing implants? From Jamil Francesca as well.
Jamil Francesca. So no, when you insert your breast augmentation, breast implant the first time, we're creating the space in which the implant lies. So most of those cases are below the muscle. At least for me, I put them all below the muscle. Once that pocket is created and is healed and it looks good and you're happy, we recommend you replace implants roughly every 15 years. When you go to do that, the surgery should be significantly easier and quicker, because all you're doing in that instance is opening up the pocket, which should be, even if you've had a lift, it should be no bigger than an inch, taking the implant out, putting a new implant in, closing, and going about your business. So pain should be minimal to nothing. Swelling, minimal to nothing. Recovery should be significantly less. So, and cost should be less, because your surgeon isn't doing all the work that he or she did the first time. So the second time around is much easier. Again, that's assuming you don't have any problems. Right. Capsule issues, sagging breast, blah, blah, blah. I love my breasts. It's just time to change them out.
Do you do breast reduction revisions?
So why this question is interesting. So pay attention. The question was, do I do revision or redo breast reductions? So what would be the reason to do it? It's either the first breast reduction was done crappy, or your breast tend to grow. You did it when you were 16, and then you needed it again when you were 40. The reason why this question is important, it's not like redoing a breast augmentation, because when you do a breast reduction, you are removing breast tissue the first time. Your nipple and your areola, the pigmented area, is alive, and blood is coming into it and it's alive. When you do a breast reduction, you have to disconnect that nipple from almost all of its blood supply in order to bring the nipple from the bottom of your breast to the top. Because every reduction is a lift. You're lifting up the nipple while you're reducing it. So the blood supply has been truncated or removed while you're removing breast tissue. Obviously, you have to keep the nipple alive, so you leave one main connection. We call that a pedicle. That's the pedicle that gives blood supply to the nipple. That needs to stay alive, and the nipple survives the journey, and you're done. That's why when we say you get a breast reduction or breast lift, there's a risk of the nipple dying. The issue is that when you go back to do a revision, you're usually not doing a revision in your own patient. And so the patient comes in and says, I want you to do another reduction. The question is, which pedicle did they use when they did your surgery the first time? There's no way to know from the outside. The only way to know is if they read the op report. So the risk of redoing a breast reduction is that the next surgeon, when they go in to remove breast tissue, could accidentally remove the remaining pedicle, in which case your nipple is at a very high risk of dying or getting necrosis. So that's why this question is critical. It's not so much you can redo noses, you can do rebreasts, you can redo facelifts, you can redo eyelids. It's not the redo part. It's the redo breast survival of the nipple part. So if you go get a breast reduction, here's my suggestion to you. Make sure you get the op report and save it somewhere so that in 10, 15, 20, 30 years, you go do it again and you don't go to that same surgeon who, mind you, will have no idea what he did because he won't remember. You can take that to your next surgeon and show them. We'll take a break. We'll come back and we'll keep answering all your interesting questions. So stay tuned. We'll be right back. All right, welcome back to Plastic Surgery Uncensored. It's your host, Dr. Rady Rahban, and my co-star, Maria / the producer. And we're answering your questions, and fire away. What's the next one?
Well, it's a breast day, so let's continue with the breast.
Stay with the theme.
Right. Amy Bridget says, can a woman always tell if her breast implant has ruptured?
You guys are asking some good questions. I'm proud. Amy Bridget's good question. So the question is, can a woman always tell if her breast implants are ruptured? And the answer is depends. Number one, if you have a saline implant, that is a silicone gel outer shell with saline filled, you will know within 24 hours if your implant is ruptured. You wake up one morning, you'll probably be in the Bahamas or somewhere really important, and your right or left breast will just go psh and deflate. It's a water balloon. So for whatever reason, if it were to rupture, it will suddenly deflate. Seldom do you get a partial rupture of a saline implant because, as you can imagine a water balloon sort of breaking. It just breaks. So if it's saline, you'll know immediately. And truthfully, that's the only, in my opinion, benefit of a saline implant, which is far, far outweighed by all the things about it that I dislike. So I'm a big fan of silicone implants for 1,000 other reasons. And of course, as always, there's an episode that talks about it. But if it's a silicone implant, it'll be a silent rupture. That's right. You won't know. You won't know because there's nothing that changes. So people often say, oh, Dr. Rahban, I'm here. I think my breast implant is ruptured. And I said, well, what kind do you have? Silicone. And I'll say, how do you know? And they'll say, because it's getting smaller. That's impossible. Silicone that ruptures doesn't get smaller because it doesn't get absorbed. It gets misshapen sometimes because the round silicone shell is broken, and so it becomes a little more oblong. But it's never going to get smaller.
Could it be that they've just lost fat in the breast? And
well, whatever. If they think their breast is smaller, it's because their breast got smaller. It's not because they ruptured.
Oh, okay.
And so the only way to know if your silicone implant is ruptured is through imaging being some kind of radiographic. Now, mammograms are okay in terms of determining if the implant is ruptured, but they're not great. As a matter of fact, truthfully, they probably cause I don't know, half of the ruptures, because when they squeeze the hell out of your breast during a mammogram, they can break the implant. I mean, it's just the reality of an old implant. But the gold standard imagery wise is an MRI. In other words, you go get an MRI, the MRI will tell you if it's broken. Okay. The other way is surgery. So literally last week, I did 2 surgeries, 2 women. Their implants were in quite some time. And 2 of them, we found what we call a silent rupture, meaning when I went in to go exchange them, because it was time to exchange, they were broken. So now, of course, the natural question is, oh shit, what's the ramification of that? And other than it being kind of sticky and gooey and a little annoying, the implant is broken. There's no real major ramification, although the rate of capsular contracture, hardening your breast goes up because the silicone is inflammatory and annoying. Am I going to get breast cancer? No. Am I going to get lupus? No. But naturally and intelligently, you'd like to remove them and replace them before they break. So hence the reason why we pick an arbitrary date, 15 years. It's not like yogurt that expires on 10/22, which is also arbitrary because you know that that's bullshit. And the reason is you don't want to be driving down the highway and have your tire blow up. You want to change them under your timeline, and you want to change your implant. So if you change them 15 years or so, then you'll have no issue because they very seldom, if ever, rupture on their very own.
So you were mentioning the implant should be about approximately 15 years. Does it make a difference if it's silicone or saline? Because L. Getman says, how many years can I go with my silicone implants?
L. Getman asked about how long she can go with her silicone implants. So the truth is that if you have saline implants, technically, if they look good and they're not causing you any issue, I usually tell patients you can leave them alone. Because when they break, you will know. If you have silicone implants, it'll be silent. You won't know. Now, the reason why you want to change your saline implants then is like, oh, I mean, I could just keep them for 20 years. Yeah, I mean, theoretically you could. The reason you want to change them is you want to change them on your timeline. So you want to it's like a planned C-section. It's like, I want to plan it on the day that I want with my family there. And the same thing is with the saline implant. It's like, do you have 2 options? One is to say, I'm going to change them at 15 years. They're not broken. I may have gotten a few more years out of them, but I'm going to do it while my kids are on holiday and blah, blah, blah. Or you go and just use them. And then when you're in the Bahamas and you're on this vacation and it's your second honeymoon, they break. Now what? Now you're screwed. So I think you should just change them every 15 years. It's not like you're doing it every 2 or 3 years. I mean, for God's sakes, 15 years is a long time.
Yeah. We have here, Yu-Hu Choko. Do you perform vertical incision reduction for lifts?
Yu-Hu Yoko?
Choko.
The question is, do I do vertical reduction lifts? So the answer, and the reason why this is important is I do whatever I think you need in order to get the best outcome. So what she's referring to is the pattern or the scar you see on the outside with a lift. So when your doctor does a lift or a reduction, he or she needs to cut on the outside in order to do the surgery. This whole scarless BS crap, I'm not a believer of. I'm not going to get into that now. You know, people are doing scarless lifts and scarless this. I don't believe in it. Mm-hmm. So you need a scar, and the scar then becomes the major issue, and people want to avoid as much of a scar as possible naturally. So you have a donut, means the incision is around the areola. You have a lollipop, which means the incision is around the areola and straight down the middle of the breast, which is the one she's referring to, which is a vertical. Mm-hmm. And then you have a anchor, which is around the areola, down the breast, and in the fold. And I do all of them, but I do the one you need, not the one you want. Yeah. Right?
Usually works that way.
Yeah. So yeah, of course, if you need a vertical, you get a vertical. But if you come in and you want a vertical, but you need an anchor, and then you get an anchor, or you get someone else to do the vertical.
And unfortunately, there will be someone that will do it. Maybe not.
No, I mean, listen, do you know how many revisions I've done in the last 15 years that the conversation begins with, well, they told me I could get away with. Just listen to that conversation. They told me that I could get away with, which means that I know that whatever I'm doing is not the right thing, but it should work. Like, are you effing crazy? Like, that's one thing to say, I think I can get away with this haircut or whatever, but would you do that in getting your airplane? So the pilot says, hopefully we should be able to get away with traveling through this storm. What does that mean? No. So surgery is the same. And anytime there is a lesser path or an alternative path that is better, you take the better path, even if it's more costly or more scar, whatever. So there's no such thing for me as I could get away with. You need a lollipop, you need a lollipop, you need an anchor, you need an anchor.
Right. Well, speaking about scarring, Olive Diaz says, concerned about the scarring from a lift.
Olive Diaz. So that's exactly perfect, Maria. Good job. So that's exactly it. That's so people have fears, and the fears are, wow, I got saggy breasts. I don't like the way they look. They make me feel terrible and insecure. And the last thing I want to do is go have surgery and exchange one bunch of things I dislike for another bunch of things I dislike, which is now I have this horrific, ugly, nasty scar that I have to hide. And arguably maybe worse because you did this to yourself, where saggy breast is arguably natural. Your fear of an ugly scar is echoed by every single individual who is having anything done surgically. My wife has had spine surgery, 4 of them. She was worried about her scar. Gallbladder removal, hysterectomy, and for sure plastic surgery. But here goes my philosophies again. I am a believer. So first thing I want to do is, I had a whole segment about scars. So there is no such thing as scarless. It's just a matter of ugly scar versus, or rather unsightly scar versus acceptable or nice scar. Okay. So there are thousands of examples online of beautiful outcomes where the scar is visible, but perhaps incredibly faint. And then there are many, probably millions of examples of really shitty, ugly scars. So the reason to get a lollipop, for example, in versus a anchor should not be, well, I'm afraid of shitty scars, so I want a shorter scar. Because then you get 2 things wrong. One, you're for sure going to have an ugly breast because you're not doing the right procedure. And then the scars will not look good because they're under tension. There are techniques of closing wounds that optimize great outcomes. And then there are the average person who whips it together and does a shitty job, and you get a shitty scar. So you should be concerned about the scar, but you should not get it done because of the scar, because there are many examples of good outcomes whereby which you get both the lifted, pretty breast and really a faint scar.
Well, we have a question here, which I was kind of curious myself. Is it possible for breast tissue to grow back after breast reduction? Because a doctor that I was talking to, a gynecologist, said, oh, that she had a breast reduction. And then she did it again 15 years later. I go, oh my God, do I have to do that again if I have to do that? I was just like freaked out about that.
All right. So that's a great question. So I had a breast reduction. What are the chances or the likelihood I'm going to have to do another one? Mm-hmm. So here's the catch. In most instances, the female biology is such that as we get older, particularly if we give birth and breastfeed, our breasts tend to involute, shrink, and atrophy. So the overwhelming majority of women, as they get older and older and older, especially if they've had children, start to lose their breast tissue and get smaller. Hormones change, etc. There are individuals, they're the smaller subset, whose breasts, like their waists, like their ankles, like their hips, continue to grow either because they're getting breast tissue. After pregnancy, my breast doubled in size and never went back. I was a cute little B, now I'm a double D. Or because they gain weight. Don't forget that a percentage of your breast is fat and a percentage of your breast is glandular, actual gland. And so yes, if you get a breast reduction at 16 because you're unlucky and your breasts tend to hypertrophy early, there's a chance that by the time you're 27, 28, your breast tissue may recur. But for the overwhelming majority of women whose breasts get larger and larger, it's because they've gained weight. But the significant number of women's breasts shrink over time. So that's the answer.
Interesting. Silver Tattoos had a whole bunch of questions that you've already answered. But one of her questions was, do you lose sensation in the nipple?
Fantastic question. There are millions of women who would love to get a breast aug, breast lift, breast surgery, but are petrified of losing sensation from the surgery, since the sensation of their nipple is critical for sensual orgasm and sexual pleasure. Plain and simple. For some women, it doesn't matter. For some, it's critical. And if that's a critical part of your sexual experience, naturally, the last thing on earth you want to do is jeopardize it. So this is the skinny on sensation. The sensation to your nipple is predominantly delivered by a single nerve called the fourth intercostal nerve. In other words, the majority of the sensation you feel at the end of your nipple is produced by one nerve that is coming out of your body near your armpit or axilla. Therefore, in order for you to do breast surgery and lose the sensation, that nerve traditionally has to be damaged. Interestingly, when you do a breast lift or a reduction, depending on the pattern, how aggressive, whatever, for the most part, majority of people's sensation is pretty unchanged. And given that we cut around and rearrange and do all that, it's pretty extraordinary. You would think that from a breast reduction, oh, for sure I'm going to lose sensation. And the answer is you won't. Not necessarily. You might, but usually you don't. Where do you lose sensation then? It's usually during a breast augmentation where your surgeon goes in. It doesn't matter if it's through the armpit, through the belly button, through the ear, through the nipple, it doesn't matter. And picks a very large implant for your chest diameter. So when patients come in for a breast aug consult, we measure them. We measure their chest and we say, your chest is 12.5 centimeters, right? And then guess what size implant we pick? Smaller than 12.5 centimeters because that's the size of your chest. You wouldn't put on a shoe that's smaller than your foot, but many surgeons oversize the breast with an implant larger than the actual base because the breast stretches. And in doing so, they got to shove a large implant into a small space. And when they create the large space, they create a space in which the nerve is damaged, cut, or pulled. And so it's usually a breast augmentation of very large size that causes loss of sensation. Again, you would think cutting around the nipple is the cause, but it is not. It is damage in the armpit from a big implant.
There's a question from Joe Mo 908. Are implants contraindicated for moderately fibrocystic breasts?
So the question is, are breast implants contraindicated for moderately fibrocystic breasts? And the answer is no. It turns out that many, I don't know the numerics, but I'm going to throw out a number. 50% of women have fibrocystic breasts. I mean, they always, you go get a mammogram, they tell you your breasts are dense. You have dense breasts, which basically means you have healthy breast tissue. And the only thing that happens when you get an implant, as it is with fibrocystic breasts, mammographies are a bit difficult. They'll tell you they did your mammogram and gosh, I couldn't tell, we couldn't see because your breasts are dense. And for many women with fibrocystic breasts, they end up having to get ultrasounds and MRIs and things of that nature. And when you add the implant, it just is the same. It doesn't change your fibrocystic breast. You still have fibrocystic breast. It doesn't make it worse, doesn't make it better. Your implant is underneath, all the way under your fibrocystic breast. It's not in it, it's below it. So no. Remember, that would be like half of women who then wouldn't get an implant. So no, it's not a contraindication.
And we're going to do the last question. How long would one be out of work for a breast reduction coupled with a tummy tuck?
How long will you be out from breast and abdominal surgery? Essentially, let me recap it. How much time should I consider taking off from a mommy makeover? That's essentially the question.
Exactly.
All right. So take off depends on, as all things, it's all relative. So we need to define some things. So I divide things in the following windows. There is immediate recovery, there is moderate recovery, and there's full recovery. Immediate recovery is I work, I take care of my kids. How long do I need to have someone leave me alone, let me be, and let me recover? So from a mommy makeover, that means breast and tummy, lipo, whatever. The tummy portion makes it so that you need 2 weeks off work. If you were only doing breast, it's 1 week. If you're only doing tummy, it's 2 weeks. If you're doing breast and tummy, it's still 2 weeks. So the maximum recovery that you will ever have from any surgery that I do before you can go back to a desk job is 2 weeks. That's correct. 2 weeks. The next wave is when can I go back to the gym and be active, free, active? I want to go on a bicycle. I want to go on a hike. I want to take Pilates. And the answer to that is 6 weeks. Doesn't matter if you do breast dog or a breast lift or a tummy tuck or a reduction or a mommy makeover or a nose job. 6 weeks. And the last question is, when will I feel awesome? I want to train for the Malibu Tri. I want to be in a triathlon. And the answer is, if you take your recovery seriously, usually you'll be solid for like a triathlon between 4 to 6 months, assuming you're training. But you'll be bulletproof at 4 to 6 months. So those are usually the incremental time frames that I recommend. 2 weeks off work, 6 weeks before you can resume all activity, 4 to 6 months before you feel like a superstar. Obviously, like all things, it needs to be tailored to you and your personality and blah, blah, blah. But that applies to everybody that comes through my practice. Well, hopefully you enjoyed that episode. Thank you, as always, for tuning in to Plastic Surgery Uncensored. We solely and totally and only exist because you're out there listening. So join us next week for another episode of Plastic Surgery Uncensored. Make sure to share and follow and download and do all the things you need to do to keep us thriving and continuing. Until next week, I'm your host, Dr. Rady Rahban.
Thank you for listening to Plastic Surgery Uncensored with Dr. Rady Rahban. We would love your feedback. If you enjoyed this episode or if you find our podcast helpful, tell us why. Leave us a review and make sure you subscribe on your favorite podcast platform. If you have a topic you would like for us to discuss in an upcoming episode, please reach out to us on Instagram at Dr. Rady Rahban, on Facebook at Rady Rahban, or at RadyRahban.com.